Hello everyone, I'm Nitin Advani. We are going to talk about statistics for this presentation. But first of all, let me thank Dr. Deepak for giving me an opportunity to share my thoughts on statistics that I have for different types of research and analyzing different research papers. And out of all those lists that you're seeing on this slide, we're going to talk about diagnostic research. So the objectives of this presentation would be discuss the purpose and process of diagnosis in physical therapy, understanding how to critically evaluate research articles on diagnostic test or measures and help you understand and answer questions about the study design, discuss about the measurement properties of the study, and which statistical concepts can be applied in the particular study. Discuss considerations relevant to deciding whether to use that evidence presented in the study or not, and discuss about measurement properties. So, what is statistics? Basically, we all deal with statistics in day-to-day life. It simply means taking decisions, like in our clinical practice. It can help us take calculated decisions for favorable outcomes. For example, when you see a patient and you suspect whether this person has a rotator cuff tendinitis or whether this person has a partial rotator cuff tear, we all do different tests, and based on those tests, we come to a conclusion that this person may or most likely have, let's say, a partial rotator cuff tear. So that numbering the may and the most likely is called as statistics. Like in CPR, when let's say Weiner's cluster, if 4 out of 5 findings are present, the person is most likely to have cervical radiculopathy. Similarly, there are different um, um, reasoning and justification that okay, that we use statistics in our day-to-day clinical practice as well. So what it is, basically it is a method of collecting, organizing, interpreting, and presenting the data in mathematical formula. It tends to deal with two fundamental properties. It helps to answer about uncertainty and the variation. So let's talk about the diagnostic research. It primarily focuses on the development and investigation of methods for evaluating medical tests in healthcare. So how do we conclusively say about the diagnosis? Let's say you are measuring a person's weight, and you're using a weighing scale. How confident we are to say, okay, this person weighs about 130 pounds. Is the weighing scale reliable? Is the weighing scale valid enough? How are the measurement properties of those weighing scale regarding measuring the weight? So this is what we are going to discuss about further. So what are the purpose of diagnostic research or the test? Basically, it focuses on examination of a body part or a symptom. Let's say you're doing some diagnostic test for a shoulder, and then you're doing all different tests which involves impingement test or a partial tear test or glenoid labral tear test. All these are focusing on a body part or a symptom. It tends to identify potential problems, whether we need to treat or whether we need to send the person out or we have to treat and refer the patient out. So it helps to classify the patient whether this is a physical therapy patient or this needs some other medical care. So we're going to discuss about the key thresholds for diagnostic test. In clinical decision making, diagnostic tests play a very important role because it provides additional information that is required by clinicians. And it involves a diagnostic process which can be defined as basically process to increase or decrease the likelihood of the target disease until it is possible to rule in or rule out the specific diseases. The role of diagnostic test is to increase or decrease the probability of confirming the target disease in order to make a clinical decision. So let's talk about the test threshold. It is the probability below which the diagnostic test will not will not be ordered or performed because the probability of diagnosis is so remote. What it means is basically doing a diagnostic test will not add any value to the treatment, or it will not change the course of the treatment, or it would be very difficult to diagnose based on the diagnostic test. Or even if we do the diagnostic test, it would not hold any value or it would not add to the diagnosis. Let's take an example here. For let's say we have an elderly man, 65 years old. He had a simple rear-end motor vehicle accident, let's say yesterday. He presents with just mild neck pain with no paresthesias. He does not complain of midline tenderness and cervical spine, and he's also able to rotate his neck to 45 degrees on either side. So based on this information provided, do you think this person would need an X-ray? I don't think so, right? I think you all will agree with me that this person does not fit into the Canadian C-spine rule, and hence he would not benefit from an X-rays, and the X-rays would not show any cervical spine fracture because as per the Canadian C-spine rule, which is valid and reliable test, the chances are most likely this person does not have a C-spine fracture. So that's a test threshold for X-ray because it would not add any value to the diagnosis. So what about the treatment threshold? The probability above which the diagnostic test will not be ordered, again, will not be ordered because the possibility of diagnosis is so great that the immediate treatment is indicated. Now remember here, in both the cases, either the test threshold or the treatment threshold, in both the cases, diagnostic test is not ordered. However, let's take an example here for treatment threshold. We will take the same example of an elderly man here with a motor vehicle accident. Now this person presents with paresthesias and midline tenderness. So the very first thing that we need to do is we need to send this person out for an X-ray, or we should send the person to ER to rule out the cervical spine fracture, right? So our diagnosis is complete and we need to refer the person out, correct? Now starting if you look into the treatment threshold, where it says diagnosis completed, start treatment doesn't mean we have to start our physical therapy treatment. It means we know what our clinical decision is and we can take actions accordingly. That's where the diagnosis is complete. So in the scenario that I explained to you, this person would be a cross referral to rule out cervical spine injury because there are very high chances this person is having C-spine fracture. Okay, so that's treatment threshold. And if you notice this horizontal line which says 0% and then 100%, below the test threshold, the probability of the disease is very, very low. And above the test threshold, the probability of disease is very, very high. That's almost probability of 1 above the treatment threshold. Okay, and in between these two zones, we need more information. We need more diagnosis. We need to do more diagnostic tests to confirm the diagnosis in order to make an appropriate clinical decision. Okay. So, what are diagnostic tests? These are the tests that we as a clinicians perform, and they are all special tests, basically. Tests that are performed by other medical professionals include lab tests or imaging studies, and it could be anything: X-rays, ultrasound, MRI. What are some measures that we use in physical therapy that we base our decisions on, or for which we use the special test? It could be the range of motion, and that includes goniometry. It could be strength testing for including dynamometry, or functional limitation test. It could be lower extremity functional scale, or quick dash, or SPATI, or for disability SF-36 form. So when we see a study, or when you look at a study, how do we know the study's credibility? So we're going to talk about this. So number one question that we need to ask ourselves while reading that study is, was there a comparison to a gold standard test? So what comparison with gold standard means? So basically this portion addresses the test that being used, whether it is actually diagnosing the problem or not. How do we conclusively say that it is detecting the problem? How does it compare with the best that is available for the diagnosis? For us, the gold standard could be imaging, or could be lab report, or could be biopsy or autopsy finding. So we need to make sure whether the test that we are designing, or whether the test that is being compared, was it actually compared with the gold standard. So a reliable and a valid test is utmost important to be considered gold standard. Okay, so comparison to gold standard test allows the researcher to confirm the measurement validity of the diagnostic test of their interest. So we want to make sure the test that is being designed has good validity and reliability in order to diagnose the problem that we are trying to find. You know, um, so the next question that we need to ask: did the study include test or a measure with previously demonstrated consistency and usefulness? So again, that goes to a gold standard, whether that was used or not. You know, and the next question is where the individuals interpreting each test results unaware of other test results. So, for example, here, let's say you're doing you're trying to find. Let's take an example of Dr. Deepak's research here for the backward tipping test. Let's say they're doing the research now for finding of the trying to find for the pectoralis minor tightness. And if Dr. Deepak's or other clinicians or the investigator know, okay, this person has right shoulder pain, or he's in the clinic for the right shoulder pain, and now you're comparing the pectoralis minor tightness between right and left shoulder, we will be tempted or prompted, or we might tend to believe that, okay, this person has a right shoulder problem, rather than relying on our decision and comparing from right to left. So having prior information about the other test result can affect the outcome of the test that we are trying to design. So masking the individuals responsible for testing increases the validity for by minimizing the tester bias. So let's say if I want to do a research on dry needling for posterior capsule of the shoulder, and we're trying to compare if the traditional posterior capsule stretching is more effective or not compared to dry needling for improving glenohumeral internal rotation deficit. So if I'm the person who is dry needling the patient, and if I'm also doing the range of motion testing post needling, I might be biased in my experimental group, let's say dry needling group, to imagine, okay, these person should show more range of motion. So I might be trying to measure in such a way that I might end up doing a tester bias. So having prior information about the previous test could influence how the tester read the comparing test on the same individual on the second test. So another example, let's say I'm learning, let's say, a diagnostic ultrasound, and I did a diagnostic ultrasound on a patient with an ankle sprain, and I suspect, okay, this person might have a grade 2 tear. And then I'm doing, or let's do a vice versa. I'm doing a clinical examination on an ankle sprain patient, grade 2 ankle sprain, and I suspect some instability in the ankle, and I think, okay, this could be a grade 2 tear. And now I'm doing an ultrasound examination. So what I'm doing, I'm trying to look for that grade 2 tear now, because I have the prior information, okay, this person might have a grade 2 tear. So this is called as a tester bias. I'm diving into my beliefs that this person or the patient might have grade 2 tear. So having prior information about the previous test could influence how the tester read the comparing test on the same individual on a second test. In any statistical investigation, we can always attribute some of the variations in data to measurement error, part of which can result from the measurement instrument itself. But we as humans make mistake too, especially recording errors like misreading a dial, incorrectly writing a number, or not observing an important event, misjudging a particular behavior. They all can contribute to variability to the measurements, and thus it can affect the results of a study. So random error, basically, they are non-systematic in nature, and they are beyond our control. However, the effects of random error gets averaged out over the set of measurements. For example, let's say you have a weighing scale and you are trying to measure a person's body weight, and you check it 10 or 15 times. So if the machine is, even though if the machine is calibrated and if it is giving you an inconsistent results, let's say zero point 0.2 pounds here and there, then 0.1 pounds here and there. So once you average that out, and if you calculate the mean, that random error reduces. So that's what it means. If we average out the set of measurements, the random error decreases. But what about the measurement bias? The measurement bias are basically systematic in nature. What it means is they occur because of poorly measuring the outcomes or poorly measuring the results. Let's say you want to measure the height of a person and you have a measuring tape with you, but you're not placing the measuring tape all the way to the ground, and then it can lead to a measurement bias or measurement error. And each time you do it, you're not placing it to the ground, and each time it gives you the wrong reading. So the measurement uh, is is poorly, this because of poorly measuring technique. And remember one thing, measurement is never perfect. We can always expect some type of measurement errors in our data if we look in deeper. One way we can reduce the measurement error is by blinding the researchers. Let's say if I am the investigator and if I know the the control group and the experimental group, and if I'm also doing the pre-test and post-test measurements, I would be biased to look into some improvements in experimental group. So a third person who is blinded to the group will will be less likely to have a measurement bias, because the third person would not know from which group the patient is being measured. So the blinding helps to reduce the measurement bias. So let's talk about the inclusion of subjects. Why this is important. We should always look into whether participants of different levels or stages of disease were included in the study. A test that we are trying to measure or that we are trying to use should distinctively differentiate positive versus negative findings, and if possible, it should also suggest the in-between stages too. In other words, can a diagnostic test consistently produce similar results across all the positives, irrespective of their disease stages, to prevent the false or to avoid the false negative results? How does it help? It basically helps to determine the important gradations or in the diagnosis. Now let's take an example here. Let's say we're trying to do a study to diagnose clinical ankle instability by using lateral hop test. So let's say you have enrolled 20 patients, and all these patients have either from grade 0 to grade 3 ankle injury, and now we're trying to find out if this lateral hop test can differentiate between grade 0, grade 1, grade 2, grade 3 ankle sprain precisely, rather than just simply saying, okay, this patient has ankle instability, and X person does not have instability in the ankle. So it should also precisely differentiate based on their performance whether the person is having grade 0 ankle sprain or grade 1 ankle sprain or grade 2 ankle sprain or grade 3 ankle sprain. Okay. So regarding the manipulation bias, now the next question we should ask, or we should look into the study, whether the subjects undergo both test, the test that is being designed and the gold standard. So this is of a concern when subjects are judged to have a very low probability of being tested positive on a diagnostic test that is being developed. It can help to explain false negative, and to improve the diagnostic accuracy of the test that is being developed. Was the sample collected in such a way that some members of the intended populations are less or more likely to be included in others? So what this means, so I'll give you an example of a a a case, or a research that was done. It was for the clinical prediction rule for lumbar manipulation in patellofemoral pain syndrome, done by Iverson et al. In 2008. So what did basically, they recruited patients from active military duty, and the volunteers were between 18 to 50 years of age, and had a clinical diagnosis of patellofemoral pain syndrome, provided they were active military healthcare beneficiary. So, and that case, that research included 50 subjects, 26 male, 24 female. The age range was between 18 to 45, 50. Um, and who were active in military healthcare. Um, so what this study did, basically, they came up with different CPR findings, like what predicted a successful outcome of lumbar manipulation for patellofemoral pain, and they came out with a few findings like differences in hip internal rotation, ankle dorsiflexion, navicular drop, and painful squatting, stiffness in the morning. So these were the um, one, two, three, four, five predictors for lumbar manipulation in patellofemoral pain syndrome. But here's the catch: what they did is they included patients who were active in military and who had either the family members or the military personnel itself. So what does this do? Basically, it's called as convenience sampling. So can I generalize the findings to the other person? Maybe, maybe not. So we need to take it with a pinch of salt because that could lead to a manipulation bias. Okay. What about the reproducibility? Was the study repeated on a second set of subjects? So let's take about the same example of CPR for lumbar manipulation that we talked about. As this was done in the military population, was it done in the other population to generalize the result? Can it be reproducible? I don't know. Nothing has been done after that. So we don't know whether this study can generalize in the other population as well or not. What are some additional concerns? Is there a detailed description about where the study was conducted, whether the outpatient, whether it was home care, or whether it was done in the patient's house? Was it a group setting or individual treatment sessions? What was the inclusion criteria or the exclusion criteria? So having a detailed information about inclusion and exclusion criteria can really tell about the study design, because this is very, very crucial about who we treat and who not to treat for our research protocol. So were there any standardized protocols for the program? Let's take about the recent research paper that we discussed about, the individualized manual therapy and physical therapy combined with dry needling for non-specific shoulder pain. In that research paper, um, there was not a clear instructions who got what type of manual therapy, how many sessions, or how many techniques of manual therapy they had gotten. So that also raises a concern: was the treatment protocol standardized enough? And same thing in the dry needling too. It was not mentioned what all trigger points. They just mentioned all the trigger points that they were planning to do, but they did not mention what were the more common trigger points that were needled in the sample population. So again, that raises a question about the standardization of the treatment or the protocol in the study. So what about the study results? Were the results stable enough? Yeah, because the stability is the key to predict um, um, how the outcomes will be. So let's say when we want to make sure we keep the measurement scales or measurement techniques similar through the entire study. We don't want to use let's say you want to measure the height of a person. One time you use a measuring tape, and other time you're using your hand uh, width to measure an approximate height of a person. So it's not going to yield stable scores each time. So we want to keep the measuring process similar across the treatment or the research study. Let's say another example, you're doing a study on shoulder range of motion, and one time you used a digital goniometer, another time you're using a manual goniometer. So that can lead to an error in the evaluation process. So use of one type of equipment during the entire research process is important to keep the score stable. Use of one outcome scale is important in the entire research process. So something like that, having a stable report outcome measures. So what are some measurement properties? So let's talk about, we deal a lot about reliability and validity because this is what we live day in and day out. Is the test valid? Is the test reliable? Can we base our decision on the positive test? Let's say a crank test or any other test. Is it reliable? Is it valid? Is it helping us to answer the unanswered questions that we have? So what is reliability? You know, so we rely heavily for our decisions, as I said, on reliability and validity in day-to-day practice. Basically, reliability is composed of outcomes that includes true values, let's say true positive and true negative. And it also mentions an error, how much error, or this error may be the result of subjects included, or it could be from the observer, or could be instrument or environment, you know. So it tells us whether the the outcomes are consistent or not, whether we can reproduce the same finding again. It explains about the stability of the measurement. A reliable test should be able to minimize the false positive and false negative errors and consistently provide us the true results. So, does the same measurement um, yield stable and consistent result when repeated over the period of time? You know, that's the reliability. For example, let's say in construction world, let's say 1 foot long wood log would measure 12 inches on a measuring tape, okay, and would consistently measure 12 inches each time you measure it appropriately, right? Let's say you got a measuring tape, you're measuring that wood log in the morning, in the afternoon, in the evening, or let's say you do it again tomorrow or day after tomorrow. The tape measure will yield 12 inches each time you measure that wooden log, provided we measure it correctly. So what it does, it gives us the reproduction of the same 12 inches. The scores are stable and the scores are consistent. So that is what is reliability. Another example, let's say you're running on a treadmill. Now, irrespective if the treadmill is new, old, or refurbished, if you're running on 6 miles per hour, the machine should show that this running speed is 6 miles per hour, irrespective if you're running on an inclination, let's say 2% inclination or 4% or 6%, whether it is new, old, or refurbished equipment, or if you're doing it morning, evening, or afternoon. As long as that machine is calibrated well, if the machine says you're running on 6, it should ideally be running on 6 miles per hour. So that is what is the reliability. But what about the validity? What validity means? Validity means the extent to which we are measuring what we hope to measure. So let's take the same example of wood. A good tape that has been created with an accurate spacing between the inches or the feet would measure 12 inches of wood each time we measure the wood. So reliability would yield consistent result, whereas the validity would yield accurate results. Okay, and we need both for research: consistency and accuracy. Consistency goes to reliability, accuracy goes to validity. So another example for validity would be assessing the aerobic fitness of an athlete by 50 meters swim. That's a poor validity because that doesn't necessarily test the aerobic running fitness, right? It just tests the general endurance. So if you want to test the running fitness of an athlete, you want to make the person run, let's say 5K or 10K or half marathon to check the person's aerobic running capacity or the fitness ability. So that's when it will yield the accurate results. Okay. So let's discuss a little more about the types of reliability now. So we have four major types of reliability. Five major types: inter-rater, intra-rater, test, retest, parallel forms, internal consistency. So what is inter-rater reliability? Now let's say you are three people listening to my lecture, okay, and you three are going to rate my presentation, okay. One person rates it um, 5, other person rates it, let's say, 8, and the third person rates it 10 out of 10. So can you see there's a variation in how three of you are rating me? Now let's say another scenario here. There are three judges in a dance competition, and we are judging for a dancer's performance. And all of the judges judged the performance as 10 on 10 for that particular dance. So this tells how much or by how far the three judges are agreeing with each other for that particular performance. So let's take another example here with the Dr. Deepak study regarding the backward tipping scapula study. What they did is basically they had three investigators, Dr. Deepak, Raghu, and Ramesh, and they had three. They all three were um, checking patients with shoulder pain for their shoulder pectoralis minor tightness, and they compared their agreement of pec minor tightness, whether it was right or left, and they found out there was 86% agreement between Dr. Deepak, Dr. Raghu, and Dr. Ramesh. So how do we know if that 86% was good or not? A score. So what the research world says, a score beyond 0.85, that means 85% correlation, indicates objective competency between two or more raters and is considered good inter-rater reliability. So we want to make sure the person who is judging it or who is evaluating it or who is measuring it are consistently measuring or answering correctly. Okay. Now, what is intra-rater? So intra-rater basically means it measures the degree of agreement upon repeatedly testing the same thing by the same evaluator. So let's say I'm doing range of motion evaluation on a shoulder patient for flexion in supine position, and I found out it was, let's say, 140 degrees of flexion. Every time I do that, within, let's say, 5 minutes or 2 minutes, I'm rechecking the shoulder flexion. It should consistently say the same degrees that I found at the first time. It should not vary too much. If it says 130 once, if it says 140 other time, so there's quite a bit of difference, and that can lead to a poor intra-rater reliability. The third is the test-retest reliability. So here, what it means is you do a measurement at first, and then after some time, you do another test on the same person for the same thing. So let's say I did the range of motion examination for a patient, and after, let's say, a few minutes, I do another measurement. Okay, so mm, or let's say another example, measuring body weight repeatedly in 2 to 3 minutes. So the answer is it should reflect similar number. So that means you're doing test and then retest 2 times. Now remember what is important here, the time lapse between the two tests. Because if the time is too much, it can affect the measurement score. So time lapse is important here. How much time between the two tests. If we do it faster in between, it can give more consistent result. And if I do it, let's say test 1 today, and if I do test 2 after 2-3 days, the scores could be different. Okay, so what are some numbers that indicates test, retest, or the reliability is good? So reliability goes with the R. Okay, R score between zero point 0.0 to 0.25, there's no consistency, there's no relationship. R score of 0.26 to 0.5, there's a fair degree of relationship or consistency. R score of 0.5 to 0.75, moderate to good reliability or consistency or agreement, and R score of greater than 0.75, very good to excellent agreement or relationship or findings. So same thing in Dr. Deepak's study. For the backward tipping study, they found out the agreement between the raters was 0.86, so that was 86%. So it's a good reliability. So what's the other um, um, reliability? So it's a parallel form reliability. So what it means basically, let's say you want to um, design a new scale. Okay, take an example here that we're taking lower extremity functional scale. Okay, let's say it was designed originally of 80 questions. Okay, now you'd say, okay, no, this is too big and we want to cut down and make it a shorter version of it so that we can use it clinically. It's more user friendly, time friendly, and possible for everybody. And then you decide that, okay, we are going to break it down into two um, parts. It's, let's say, LEF, lower extremity functional index A, and then lower extremity functional index B. Okay, now what you're doing is you're trying to correlate whether the A and the B results the same degree of agreement between um, each other or not. So you're trying to find out whether the A and B have have good parallel forms of reliability, whether these A and B correlate with each other. Are they measuring the same construct? Are they agreeing? What it means is, do they have the same mean and variance? And that is what is important when we look into the parallel form reliability. Whether the two tests that are divided, are they having the equal mean and the variance? The next is the internal consistency reliability, and many times we come across this in the research paper. It measures the consistency of agreement across the items within a test. It is used, or it is measured using Cronbach alpha score, and it ranges from infinity to 1, where infinity means very, very poor relation or consistency, and 1 means great consistency and relationship. It verifies the association of answers to a set of questions designed to measure the same concept or construct. let's say you're developing an outcome scale here, okay? Say it has 10 questions or 10 set of questions, and the patient has to rank those questions from 1 to 5, and 1 being the mild and 5 being the worst, okay? 10 questions, and they have to rank it from 1 to 5, 1 being mild and 5 being worst. Now, some of the questions, let's say in the test, include placing an object on high shelf, clapping overhead, changing, let's say, a light bulb overhead. So if you notice all these three questions that I mentioned out of 10, for example, placing an object high on shelf, changing a light bulb overhead, or clapping overhead. So all these questions have some overhead movement. So a questionnaire will have good ICR, internal consistency reliability, if that patient ranks these questions fairly close with respect to severity. Let's say a patient ranks these three questions 3 out of 5 difficulty. What it means, they are equally difficult. So we have changed the format of activity, but it is still the same construct. That's the overhead movement. So, but if the answers are way too different, let's say in one over clapping overhead, that patient says 1 out of 5. Now, other changing the light bulb 5 out of 5, and placing an object on a high shelf, it's, let's say, 3 out of 5. So there is a quite a bit difference, or different answers, and they're not. So what it means, there's a variation to the answers, or to the construct. In that case, what we need to do is either we need to come up with questions that are framed appropriately, or we need to reframe those questions so that the patients could understand better, or we need to eliminate and add some other questions to design a proper outcome scale which will have a better internal consistency reliability. So what if the Cronbach alpha level is 0.95 in an outcome scale that you're trying to design, okay? So here's the catch, and it is good to have a good Cronbach alpha of 0.95 any research study. But when you're trying to design an outcome scale, very high reliabilities are not necessarily desirable. Remember, this is for outcome scale, designing an outcome scale, as this indicates that the items that we have included in the scale may be redundant. Okay, so as we talk about with the previous example of 10 questions, and 3 of them were trying to assess the overhead activity, and in all of them the patient says 5 out of 5. So and let's say there are 2 more questions in the same 10 set of questions which also ask about the overhead activity, and person still says 5 out of 5. So does it mean you're assessing the patient and the patient is answering correctly? Or are we asking the question repeatedly the same thing, and it might indicate these questions may not be necessary, or these number of questions may not be necessary to be specific. So having a very high reliability for designing an outcome scale may not be necessarily, because it may indicate the items or the test items may be redundant. So the goal in designing a reliable instrument is for scores on similar items to be related, having a good internal consistency, but for each should contribute some unique information as well. So not all have to have the overhead activity. They need to have some different unique information, that should be able to give you a little more information. Let's say opening and closing the door, or let's say lifting it at the shoulder level, or lifting it below the shoulder level, or lifting from overhead. So that also provides a good valuable information in an outcome scale. Now note further that Cronbach alpha is necessarily higher for tests measuring more narrow constructs. Okay, so if you have um, only 5 questions in the outcome scale, it might have a higher alpha score compared to more broad generic scale. Now don't get confused here when I say alpha score. That alpha that we read as alpha 0.05, that's a different alpha compared to this Cronbach alpha. Okay. So what about the validity? As we discussed earlier, validity is about how accurately we can measure what we want to measure, how accurately it predicts um, the measurement of interest. Um, Validity is equivalent to a person, how accurately we claim the 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 measurement is correct. So for example, how likely the hand dynamometer will measure the grip strength. As we know, hand dynamometer is reliable and valid. It has equal spacing from 1 pound to 2 pound, 2 pound to 3, and so on. So from 5 pound to 10 pounds, there's equal spacing. So that's where it predicts accurately what the grip strength is. But we can't say the same thing when we use a putty dough to check the grip strength. We don't know what the grip strength is depending on the different types of putty. All we know it just offers different different color offers different resistance, but we don't know what and how much the grip strength is based on the putty color. So basically, it is the degree of probability to which the tool measures what it claims to measure. How correctly it measures, how accurately it measures what we want to measure. So validity is important because it helps to determine what types of test to use and helps us to make sure researchers are using proper methods, because if the measurement of interest is not valid enough, we won't know how accurately the test has measured um, for example, let's say range of motion, or take an example here. Let's say we want to check strength testing of a person, and now every different therapist may have a different reading, and so we can't say how reliable that method is, but we don't also know how valid it would be, because it might differ from a novice clinician to an experienced clinician. So but when we have a set measuring tool, let's say a measuring tape with an equal spacing, or a hand dynamometer with equal spacing, so all these are valid tool as well, that has accurate spacing or distance between from one. So how validity is different from reliability? As I discussed earlier, um, it is reliability is about consistency of a result or the measurement, and validity is about the accuracy of the measurement. Let's say you're taking body weight of a person, and that person weighs ideally 130 pounds, but each time you're weighing that person, the measuring scale says 128 pounds. So what does that mean? That person body weight is showing up 2 pounds less than what it is, right? So, but each time they are checking it, the machine is showing 2 pounds less than what it is. So the machine is consistently showing 128 pounds. That means the machine has good reliability. But what about the accuracy? What about the validity? The machine is consistently showing 2 pounds off in the measurement. So that means the machine is off. That means the machine has poor validity because it's not showing the accurate body weight. So um, a, a, a test cannot be valid with a poor reliability. You see what I'm saying? In the measuring scale, that example that I gave you, it had a poor validity, and a good reliability. So a good reliable scale can still have a poor validity, but other way is not possible. Okay. Um, let's take another example here. Measuring patients' walking distance by calculating the yards by a therapist walking that distance. Okay. Now, for example, here you're walking the particular distance, and one can guess the rough distance our patient walked in the clinic. Let's say you're doing a gait training, and now you want to measure how much that patient walked in the clinic, and now you're judging, okay, my 2 steps means 1 yard, and so you walked that particular distance and you're trying to measure an approximate distance the patient walked. So now each time you walk the same distance, it may not be consistent, right? We may get different uh, number of yards or field, and each time it will yield different scores. So it is not a reliable method. Hence, it cannot be valid as well because it isn't accurate too. Okay, so this is a different perspective of it. Now, if we use, let's say, a yardstick, okay, with a yardstick, which is about 1 meter, let's say, um, and which has a fixed length here, right, to measure the distance. Now you're measuring that patient's walking distance by using the yardstick, and by placing the stick repeatedly at the same angle in the same direction, right, would change the score. Hence the result could be much more better depending on how we place the stick. So if we place the stick, let's say, in line, the numbers would improve. But if we put it at an angle and then at a different angle, that measuring distance might change. You see where I'm going? So let's think about it again. So you have a yardstick. Okay, it is about 1 meter, so it is a fixed consistent distance. That means good reliability, but the results might vary depending on how and where we place the stick. So if we place the stick one at at an angle, and then other second time at a different angle, so we're not going straight to that distance. We are going, let's say, to the left first, and then the stick is on the right the second time, so the distance might change because it's not vertical now. So again, it may not give us a valid number compared to what exactly it is. Okay, so what are types of validity? So face validity, it basically refers what the face value of the test or the device looks like. Does it look like the hand dynamometer will measure the grip strength by looking at it? So it's one of the weakest way to demonstrate the validity of a tool or a test. The next is the construct validity. Basically, the term construct validity could be misleading, because it often makes people think how an experiment is physically constructed or designed, but it is a little different. It asks it refers to whether a scale or a test measures the construct adequately, whether the process of measuring accurately represents the truth or the reality. So, for example, here, let's say there's a doctor who wants to test the effectiveness of painkiller on chronic back pain. Now, every day, that doctor prescribes, let's say, pain medicines to the patient and ask their patients to rate their pain level on a scale of 1 to 10 when the pain exists. So we all know that pain exists in those chronic back pain patients, but it has to be measured what they are saying subjectively. In this case here, the construct validity would test whether the doctor actually was measuring pain and not numbness, discomfort, or any other factor, let's say anxiety or anything else. So we want to make sure the doctor was trying to only measure pain by giving pain medicines. Therefore, I would say it's a measure of how well the test measures what we are trying to measure. Now, construct validity is very valuable, especially in research or the social science research that we do. Um, so, in other words, let's say you're trying to develop a test, okay, and you're trying to measure, let's say, an IQ of a person from that test. And what you do is you did the testing from the test that you designed or the outcome measure that you designed, and now you're comparing with a widely accepted measure for IQ testing, and now then you're comparing between your outcome measure versus widely accepted, and how well that your test dictates or explain the IQ of a person compared to the widely accepted or the gold standard accepted test, whether the contents or the construct or the questioning of the IQ outcome measures in your test justifies or explain the similar level of IQ with the gold standard IQ test. What about the content validity? Um, so basically, if I would say face validity and content validity are fairly similar in a way. Basically, a universe of items are defined that we systematically sample them within the universe to create a test or a sample or a scale of measurement. Now, this approach assumes to have good detailed description of the content. So, for example, all instruments of hospitals are combined, and later a person is asked to separate the PT's equipment from the bunch of the items laying around. So, let's say you're a physical therapist, you're sent in a location where all the equipments are kept that are from the hospital, and then you as a physical therapist are asked to take the contents out that are related or pertaining to the physical therapy. So what you would do, you would accurately take it out. So that's the content validity. So taking out or finding, having a detailed information what items correlate to your particular field. So you want to come up with a new outcome measure, let's say for the shoulder, but if we include functional activities such as sit to stand or stepping, then it can affect the content validity because it's not related to it. You see where I'm going? Before, earlier in the example for the hospital, there were different items and you were asked to take out the physical therapy items, right? One particular set of items relating to a particular field, right? Now, in another example, you want to design a new outcome measure, let's say for the shoulder, but if we include the functional tasks such as sit to stand or stepping up or walking, it doesn't test the shoulder, then it affects the content validity of that outcome scale. Okay. What about the criterion related validity? So criteria related validity refers the relationship between the test that we are intended to measure and compare it with the gold standard. So basically, this type of validity is used to measure the ability of an instrument to predict future outcomes. It is usually determined by comparing two instruments' ability to predict the similar outcomes with a single variable being measured. And it has four main types of it: concurrent validity, predictive validity, convergent validity, and discriminant validity. And we'll talk about all four of these. So let's go to concurrent validity. So concurrent validity measures the extent to which there's an agreement between the two simultaneous examination for the same um, behavior. For example, here, let's say you're designing a new special test that will detect a rotator cuff tears at an early stage. And now what you're doing that special test, and then you're doing the uh, gold standard, let's say arthroscopic examination in those patients. So what you're doing these two tests at the same time, one after the other, and you're trying to compare if there is a good agreement between these two tests that you are doing. So they are trying to assess the same behavior of whether there's a rotator cuff tear or not, and you're trying to assess the agreement between these two, and that's called as a concurrent validity. What about the predictive validity? It basically means the extent to which the future is predictive. So it's an educated guess or calculated judgment. For example, let's say you're developing a return to sports criteria and ACL repair patients. Um, does the criteria actually, when you come up with a criteria, let's say, does the criteria actually predicts the athletes who fulfill the criteria reduce the likelihood of re-tear? Say ACL injury, and then you did the rehabilitation, and now there are, let's say, 5 items, and they all a patient fulfills all these 5 criteria. Does that reduce the likelihood of ACL re-tear when the patient enters into the sports again? Now, another example could be, let's say, before elections, how accurately a political poll measures the future voting results. Now, the very important thing that you want to remember here is time lapse is the key to the predictive validity. Now, if you did the political poll 1 year before the actual election, and many things can change. So the time lapse between the patient qualifying the sports criteria, return to sports criteria, and then the same patient entering into the sports 1 year after you had completed that criteria, or when the patient fulfilled that criteria, many things can change in between. So another example, let's say from the previous example that we did, orthoscopic versus special test. If the tests are further apart than they should be, it can lead to an inaccuracy in predictive validity. Because if the same person is doing the, let's say, industrial job, and initially you think, okay, this person does not have rotator cuff tear in your special test, but 6 months later that same person underwent an orthoscopic examination, and that orthoscopic examination said there is a minor tear in rotator cuff, one of the rotator cuff muscle. So how well we can say um, there's no way to compare it because the time lapse between these two were much more, so the predictive validity suffers in this case. What about the convergent validity? It simply means that the degree to which a measure correlates with other measures designed to assess the similar construct. So tests are already developed and now you're comparing it with something else. Let's say ultrasound examination for rotator cuff tears versus orthoscopic examination. And you're trying to find out how well they arrive at the same conclusion, how well they measure, how well the measurements are correlated. So the both examination, the ultrasound examination and orthoscopic examination, are done to assess the same construct, to see whether the findings are correlated or not, so whether they can arrive at the same conclusion or not. So what about discriminant validity? It basically means degree to which a scale can differentiate or discriminate between two different results when measuring two different constructs. This could be slightly confusing between the convergent and discriminant validity. So the basic difference between convergent and discriminant validity is that convergent validity tests whether the construct that you're trying to measure and you think is related are actually related. Discriminant validity tests whether the believed unrelated constructs are in fact unrelated. So let's take an example here. Okay, you're trying to find out what all factors could affect the balance. Okay, now you think, okay, there is strength, there is age, there is vision, all these factors can affect the balance. And now there's another example here, emotions. Do you really think the emotions would affect the balance? Maybe not. So the discriminant validity should accurately differentiate the strength, age, and vision versus emotion, because emotions would not affect the balance. So discriminant validity test whether believed unrelated construct like emotions in this example are in fact unrelated in divided by specificity here. So specificity is D divided by B plus D. Okay. All right. So that's the negative likelihood ratio. So this is the examples and the formula that I was talking to you about. Specificity A divided by A plus C. Sensitivity A divided by A plus C. Specificity D divided by B plus D. Positive likelihood ratio A divided by A plus B. Negative predicted value D divided by C plus D. Positive likelihood ratio A divided by A plus C divided by 1 minus D. I'm sorry, I have forgotten to put the division mark here in positive likelihood ratio and the negative likelihood ratio. So that's my mistake here. Again, positive likelihood ratio is A divided by A plus C. So that's the sensitivity divided by 1 minus specificity. That's D. Again, there's no division sign here that I've forgotten. Divided by D divided by B plus D. Same thing with the negative likelihood ratio. It's 1 minus A divided by A plus C. So 1 minus sensitivity divided by D divided by B plus D. So that's specificity. Okay. This example again. For example, think about for a second if the positive likelihood ratio of the patellar compression test was 1. Okay. For example, just guess. Okay. So it would be somewhere here, and the prevalence was 29 for that the patellofemoral pain syndrome. So 29, that will go to 1. We are assuming as positive likelihood ratio of 1. that will just go to somewhere 30, I would say at the most 30% post test. So it doesn't change significantly. What it means is, so if the test has one value of likelihood ratio, there's a 50-50 chance of increasing or decreasing the probability of diagnosis in post-test, because it will all depend upon the pre-test probability, what the value of pre-test is, because the one is median in the likelihood ratio. Okay, so if the study has 95% confidence interval with one value in likelihood ratio in the bell curve range, means that one probability for the true value of likelihood is 50%, 50-50 chance, or could be a chance either above or below. Okay, so the question is, should we use the evidence that is presented in the study? So we need to ask some questions to ourselves, whether the study that was done had high quality, or whether there were enough attention given to minimize the bias or the different types of biases. Are the results important enough to use? Whether they had any significant effect size. If I say, let's say, Mr. X, he's a physical therapist, he let's say earns $60,000, and now he has a salary raise, and from tomorrow he's going to get $60,000 plus one, so 60,000 plus $1. So statistically or mathematically, that person, Mr. X, had the salary raise. But is it worth? Is it valuable? Does it have any significant value to it? Maybe not, or practically no difference, right? So what we need to ask ourselves here is, do the results show any importance enough to use, or is there a practical application to it? So that is called as the effect size. And is the measure or the test safe enough and practical for the application in the clinical setting? That is also a very important question we need to ask. Now, if you're designing an outcome measure which has 50 questions or 100 questions, it would not be as practical, because we are all struggling with the time in the clinical. We all have to perform and maintain the productivity level. So if there's a test that has 100 questions, the chances are more than likely we won't be using it in the clinic other than the research purposes, right? Does your patient represent the part of the sample population? So this question goes back to an example of measurement bias, or the manipulation bias that I had explained you regarding the CPR, or clinical prediction guidelines, clinical prediction rules for the lumbar manipulation in patellofemoral pain syndrome. Remember that study included patients who were the active beneficiary of military. Does your patient represents the same sample population? So you need to ask yourself whether you can take the evidence presented in the study into your clinic for that patient that you're going to treat. What about the risk or the pain of the test measure? Let's say you're reading a research on manipulation, let's say cervical manipulation. Now, as we know, cervical manipulation do carry some risk of dissecting the vertebral artery. So we need to ask ourselves a question. Yes, the research says there's a benefit. Now, how much risk it involves in using that treatment or the measurement in or on our patient? So that is the question to ask ourselves. So let's dive in a little bit more about the design of the diagnostic study. So these are very, very important questions to ask ourselves, and one of the important questions that we need to ask: how do we decide what information is important? whether is it clinically relevant. So we need to look into the standard error of measurement. So what is standard error of measurement? Basically, standard error it is a standard deviation of error of measurement that are associated with the test or instrument or any tools. um, so let's say now we know the mean, which is right at the normal bell curve at 0. Okay, now standard error of measurement means it is a measure of standard deviation from means, how far the score is being deviated from the mean. Okay, what is the use of it? It reflects how accurate the score is. Okay, anyone using the tools, or in case it can be outcome scale as well, should be aware of the standard error of measurement, because it allows us to quantify to the extent to which the scores are accurate by looking at the deviation from the mean. So any test or any study which has a low level of standard error of measurement means it has a high level of accuracy. So here, for example, let's say we will look into the lower extremity functional index. A patient who scores 46 on lower extremity functional index. How confident are we that the patient's score is actually 46? It could be few points more, it could be few points less from the actual true score, right? We don't know. There could be some error. So that is called a standard error of measurement. And in lower extremity functional index, the standard error of measurement is only 3 to 4 points. So it has a good reliability because it doesn't deviate much. Okay, how do we apply, or how is it applied? It helps to calculate the confidence interval. Remember, we discussed the confidence interval is the range from, if we want a 68% confidence interval, that would be one standard deviation to the left of the mean and one standard deviation to the right. Okay, and 95% confidence interval is two standard deviations, almost two standard, but if you want to be very precise, that is 1.96 standard deviation to the left from the mean and 1.96 standard deviations to the right. So we use this standard error of measurement to calculate the confidence interval. So what is the value, or how's the formula? Okay, the score, let's say we will take this lower extremity functional index again. Okay, so if we want, let's say 95% of the confidence interval, the score of the lower extremity functional index, for example, the patient scored 46 plus and minus. And why do we have a plus and minus here? It is because to calculate the lower bound and upper bound value. Okay, so score of the lower extremity functional index, let's say this patient had scored 46 plus and minus 1.96, and the standard error of measurement, that is only 3 or 4 points for lower extremity functional index, and you will come up with the lower bound value and the higher bound value for that 95% confidence interval. Okay, so that's how it helps to calculate the confidence interval, and it indicates how good the reliability of the study is. Okay, MDC is basically that corresponds to a noticeable change in the ability. Okay, and MCID is the smallest amount of change in an outcome that is considered important by the patient or clinician. Okay, the MCID value is the minimum value or the amount of change required by your patient or for your patient to feel a difference in the variable that you're measuring. So let's say the patient is coming here for the knee pain and you had the lower extremity functional index, or let's say patient had a total knee joint replacement, and before the MC the lower extremity functional index score was, let's say, 25, and you treated that patient for 4 visits, and now you did a recheck and now the score of lower extremity functional index is, let's say, 38. So there's a 13-point increase in the score. So what it means the lower extremity functional index improved by 13 points, and it clearly passed or increased, or the score improved by more than 9 points, which is the minimal clinical identifiable difference. Okay, so it helps to guide the clinical decision making during the course of treatment. Okay, MCID is often used in calculating the sample size to minimize the false positive type 1 error or false negative, that is type 2 error. Okay, so MCID is used to calculate the sample size for the study. A low MCID value might or may result in overestimating the positive effects of the treatment. Let's say, for example, you again had a lower extremity function index who had a MCID of only 3 points, and you do a recheck after a couple of weeks of therapy, and that patient score improved, let's say, just barely some, or that day the patient is feeling good, the family, he visited his family, or he met or played with the grandkids, and that person is happy that day, and maybe that's why, let's say, the score improved by 3 points. Does it mean the score really improved, or is it really a clinical important difference? Maybe not. Versus if the patient's, let's say, versus if the MCID score is of 20 points, it may be very hard to cross that barrier of 20 points, because that would really mean the patient would have to be running and jogging, after TKA, and that's pretty challenging. So what it means is low MCID value may result in overestimating the positive effects of the treatment. We can inflate the error, whereas a high MCID value may incorrectly classify the patient as failing to respond to the treatment, when in fact the treatment was beneficial. Okay, so that's where this comes in handy in the research. So what are relevant findings that we need to look in? We need to look into the standard error of measurement that we uh, talked about. We're going to talk about the correlation coefficient now, and the coefficient of variation. Okay, so what is correlation coefficient? It helps to find out the relationship between two variables, whether the linear relationship, inverse, or no relationship. The value ranges from -1 to 1, 1 being a very, very strong correlation, like a direct linear relationship. Okay, so what are the different types of correlation? There's a Pearson correlation coefficient, there's ICC, it's called as the interclass coefficient, and there's a kappa. Okay, what is Pearson correlation coefficient? So Pearson correlation coefficient is a correlation between the sets of data, is a measure of how well they are related to each other. It's one of the most common measure of correlation in statistics. Basically, it shows whether there is a linear relationship between the two sets of data. In simple terms, it answers whether can we draw a line graph to represent the data? Can we understand, or can we make a linear relationship between the two different data that is presented? Okay, so let's take an example here. There are 9 swimmers. What they are doing is, there are 9 swimmers will held their breath once after breathing normally for 1 minute, and once after hyperventilating for 1 minute. Okay, so there are 9 swimmers from A to I, below mentioned in the chart here on this slide, A, B, C, D, E, F, G, H, I, and now we are documenting their how long they can hold their breath after breathing normally for 1 minute. So that's your normal values here, normal breathing values. And once after hyperventilating for 1 minute. So these are the values of in seconds for how long they were able to hold their breath after hyperventilating for 1 minute. Okay, so now what we have to find, is there an association between these two variables, the normal breathing and the hyperventilating? Okay, now we do put this value in the statistical software, and we are trying to find whether there's a linear relationship or not. Okay, let's do what it shows up. So once we put this value in the statistical software, this is the value it shows up. So this is time off on the x-axis, time after normal breathing in seconds, and time after hyperventilating in seconds. So is there a correlation? Is there a linear relationship? So as you can see, there's almost a linear relationship. But here's the pitfall here, okay? it the potential problems with the Pearson correlation is it does not tell the difference between the dependent variable and the independent variable. Okay, for example, if you're trying to find the correlation between high calorie diet and diabetes, you might say there's a high correlation that people who consume high calorie diet may have diabetes too. But you cannot say other way around, people who have um, um, uh, diabetes causes high calorie diet, because it does not make sense. Okay, therefore, as a reader, you want to be aware of the data that you are reading and plugging in the statistics to find out what's your dependent variable and independent variable here to make sense of the data. Okay. So what about the Cohen's kappa coefficient? It is basically the statistic measurement that measures the inter-rater agreement for qualitative items or the categorical items. It is generally thought to be more robust measure than simple percentage agreement, as the kappa takes into the account of the possibility of agreement occurring by chance. Um, so we'll take an example here. Let's say, suppose there are two PTs, PTA and PTB. So there are two PTs, APT and BPT. And let's say you're analyzing the data on a group of 50 people, whether they have pronated feet or not. And you want to find out how much is the agreement and the disagreement between these two physical therapists in their observation for the pronated feet. Okay, so let's look into this matrix here, the table that I have presented to you on the right side. Okay, um, the PT, the first PT, the APT, says yes for pronation to about 25 people out of 50, and no to 25 out of 50. Whereas the B physical therapist says yes to 30 out of total 50 people that we are checking for pronated feet, and 20 out of 50 for no, not having pronated feet. Okay, so what we have to find out the probability for both physical therapists in observed agreement, either yes or no. So what it means is, what is the probability that the both will agree to their findings? So what is the probability? So let's look into the matrix where they both, whether they say yes or both say no. Okay, so APT says yes to 20 and the BPT says yes to 20 as well. Okay, so that's 20, and APT says no to 15, and BPT says no to 15. Okay, so that's the yes and no. That means that both are in agreement for pronation, and that's 20, and both are in agreement for not pronation for 15 candidates. So that makes total 35 out of 50. Okay, so the probability of APT saying yes for pronation, that's uh, 20 plus 5, that's 25 out of 50 total. Okay, and the probability of B saying yes to pronation is 20 plus 10, that's 30 out of 50, so that makes 0.6. So what is the probability that the both will say yes? Basically, we will multiply the probability of A saying yes and the probability of B saying yes, and that makes 0.3. And the probability of both saying no means 0.5, both saying no. Okay, so APT saying no, that's 25 out of 50, and BPT saying no, that's 20 out of 50. The values becomes 0.5 and 0.4, we multiply and the value is 0.2 when the both PT say no. Okay, what about the random agreement? Okay, what random agreement means, the probability of yes plus the probability of no. So we are adding that up and that becomes 0.5. Okay, the probability of yes and the probability of no. Now how the Cohen-Kappa is calculated is, the Cohen-Kappa, the formula for Cohen-Kappa is the probability of observed agreement minus the random agreement, the probability of random agreement, which is the probability of both saying yes and the probability of both saying no. So that 0.3 plus 0.2, that becomes 0.5. That's the random agreement, the probability of random agreement. divided by 1 minus probability of random agreement. That P bracket E is actually should be P bracket R. That's a typo here. So the formula for coin kappa to calculate is probability of observed agreement. That was 0.7 minus probability of agreement, random agreement, that's 0.5, divided by 1 minus probability of random agreement, again 0.5. So the total value at the end is 0.4. The coin kappa also ranges from -1 to 1 and indicates how well the inter-rater agreement is for the categorical data. Okay, and it ranges from -1 to 1. Okay. If you have any questions or concerns regarding this voiceover presentations, I will be more than happy to answer you all. And like I discussed or like I mentioned in the previous slide, I will give a little more detailed description of sensitivity, specificity, and all those definitions with an example in a different voiceover presentation. For the reason is we deal a lot more with sensitivity, specificity, positive likelihood ratio, negative likelihood ratio, and positive predicted value and negative predicted value. So once we have a better understanding of these, it makes a lot more sense how a test can influence our findings. Okay, so I'll make another voiceover presentation with a nomogram that will help us understand a little more about all those factors. And if you have any questions or concerns, you can either email me. My email address is nitinudvani at gmail.com. It is NITINUD as in David HAWANI at gmail.com. NITINUD as in David HAWANI at gmail.com. So you can either send me an email or um, you can upload your questions either on Moodle Cloud, and I will try to upload this voiceover presentation on Moodle Cloud. Unless I experience any difficulty, I will inform you otherwise. Again, thank you so much for listening for this voiceover presentation. I hope it did make some sense regarding the diagnostic research and how to analyze the diagnostic research. Um, I thank you, Dr. Deepak, for giving me this opportunity to make this voiceover presentation and share my 2 cents on statistics. Thank you again. Feel free to critique me. I would love to listen your feedback on this, and this will help me learn better too. Thank you again.